Yes, ma'am. We are live now. Please start.
Good evening, everyone. We welcome you to the TAPISAR Journal Club. I invite our President Sharad sir to give the welcome address.
Yeah, thank you. Thank you, Dr. Sindhuja. Thank you so much for giving me the opportunity. And I thank Dr. Vani and Dr. Sindhuja for organizing this meeting. And I'm thankful to Dr. Devika Gunshila and Dr. Priya Kannan for accepting our invitation and to be the expert commentators for this Journal Club meeting. No? So I invite both of them. And 25 years back, their mothers, Dr. Sulochana Gunasila and Dr. J.M. Khannan, they used to be very busy practitioners and academically they're so active. Now their role has been taken over by their daughters, Dr. Devika and Dr. Priya Khannan. I'm very happy to know both the generations, no, both the mothers and the daughters generations. No, so I'm uh, I'm happy to say that one and. As I already said, this lymphocyte infusion for unexplained recurrent pregnancy loss is a old concept only. 25 years back, one of my patients, she went all the way to Mumbai and had this one for recurrent pregnancy loss. Now it is getting reinvented, no, again for unexplained pregnancy losses, no. So it's becoming a treatment for unexplained pregnancy loss, and I look forward to Dr. Devika Gunsela her to share her experiences and share her knowledge, no, to enlighten us in this regard. No, same way, Dr. Priya Kannan, I too welcome her for this. Journal Club meeting, and she is going to enlighten us on indirect markers for oocyte quality in case of ovarian endometriosis, and being the embryology topic. No, so she'll be the right person to enlighten us in this particular topic. No, so I welcome all of you for this Journal Club meeting, and I request Dr. Vani Pujari to take over the session. Thank you.
Thank you very much, sir. Thank you very much for that kind welcome and all the kind things that you have said from us, from Gunchila Hospital. I think some of our fellows also are here. We are very honored to be a part of your TAPISAR. So thank you so much for the opportunity.
Thank you, ma'am. Thank you.
Good evening, everyone. Thank you, sir. Thanks for this opportunity. I will try to introduce Dr. Devika Gunshila. She's a managing partner, Gunshila Surgical and Maternity Hospital. She has, to her credit, 47 publications, 27 in indexed journals and 20 in national journals. Taking the institute forward in the realm of in vitro maturation of immature oocytes is first in Karnataka to start an in-house active PGS PGD program, has the highest number of cancer patients in India who have preserved their gametes on charitable basis as a part of fertility preservation program. She was the first to start RGUHS fellowship program in infertility along with Dr. Sulochana Gunshila in 2004 and has been running this program successfully for the past 20 years. I know so many people have benefited from this program and they are very, very successful reproductive specialists all over India right now. She has also started Institute of Academic Excellence in Healthcare to impart training to young gynecologists in the field of infertility. She collaborated with JSS University to conduct MSc Embryology course in 2013. Dr. Gunshila has established an Indian Center for Endometriosis to tackle difficult cases of deep infiltrative endometriosis. She was Joint Secretary of KISAR and Treasurer of KISAR 2014 and 2016, Chairperson of KISAR Special Interest Group for Fertility Preservation 2019-2020, Treasurer and Editor of Oncofertility Journal for Fertility Preservation Society 2022-2024, Member of Special Interest Group Applied Genetics of Fertility of Indian Fertility Society for the year 2022-2024. We are honored to have you, Dr. Devika, here. Dr. Harshita, you can you introduce Dr. Harshita and Dr. Ashwini, and so that they can take it forward. Dr. Devika, thank you very much.
Yeah, sure. Dr. Harshita is a fellow with us and has been now here for about a year. Yeah, a year, and very clever girl. And she's done her MBBS, MS, and she's done her DNB, and now she joined the Rajiv Gandhi University Fellowship course with us. She's got one presentation with ruptured non-communicating rudimentary horn with previous LSCS. But more than that, she is a very dedicated young girl and who's doing a lot of good work and also takes part in all our academic programs. So we thought that she would be good to present this paper today. And Dr. Ashwini M. Is one of the senior consultants in our hospital. She's done her MS OBG and then she also did her Rajiv Gandhi Fellowship in fertility medicine. And she's been with us for the last 10 years and is in charge of our academic program. And she's very, very strict with our fellows and doesn't let them off. Also in charge of a lot of the publications that come out. And so she's a real asset to our institution. And she's head of the teaching faculty and course coordinator for fellowship students. We also have our ISO program that has been running from the last, again, 15-20 years. And now she's the management representative. She's a member of the special interest group in fertility preservation ISAR. And together we have published several articles as well as contributed to several chapters in several textbooks. So I welcome them both. She'll be the chairperson, I think, today.
Thank you, ma'am. Thank you for your kind words, ma'am.
Dr. Harshita, you can start now.
What happened?
Shall I
I'll take
start
it
now?
over. Yeah, please start.
Good evening, everyone. At the outset, I would like to thank the TAPISAR and Gunashila Fertility Center for giving me this opportunity. Today, I'm excited to present this journal article titled Clinical Effect of Lymphocyte Immunotherapy on Patients with Unexplained Recurrent Spontaneous Abortion. It was published in Immunity, Inflammation and Disease Journal by Liu et al. Recurrent spontaneous abortion is defined as 2 or more consecutive spontaneous abortions at early pregnancy, that is less than 22 weeks of gestation, and it's a major social health problem. It occurs in 2 to 5% of the women at reproductive age, and the incidence is increasing annually. Many studies have suggested various etiologies. These include genetic factors, endocrine causes, autoimmune diseases, and infections. More than 50% of these recurrent spontaneous abortions, the cause is not known, and they are termed as unexplained recurrent spontaneous abortions. 60% of these unexplained recurrent spontaneous abortions the cause has been attributed to the defect in alloimmune mechanism, and the treatment mainly focuses on immunomodulation and hence the production of blocking antibodies or cytokines. Lymphocyte immunotherapy was first introduced by Mowbray et al. In 1985 as a treatment modality for unexplained recurrent spontaneous abortion. A meta-analysis of RCTs by Wong et al. In 2014 suggested that LIT was unable to improve the live birth rate. However, the recent analysis shows otherwise. Meta-analysis by Liu et al. In 2016 reviewed 18 RCTs and suggested that LIT, when performed before and after pregnancy, had better outcomes than that was solely performed before pregnancy. Recent RCT by Chen et al. Evaluated the clinical benefit of LIT and suggested that LIT significantly elevated the pregnancy and live birth rate as well as reduced the abortion rate, and its effect depended on the blocking antibody conversion. So studies shows that patients with recurrent spontaneous abortions are vulnerable to miscarriages with an odds of 25% at third pregnancy, 45% at fourth, and 54% at fifth pregnancy. Therefore, it is urgent to find a way to reduce the incidence of these recurrent spontaneous abortions. Now, this study was a retrospective cohort study. It included 704 patients who were diagnosed with unexplained recurrent spontaneous abortion. It was conducted at Reproductive Medical Center of Michu People's Hospital, China, between January 2014 to December 2019. This study was approved by Ethics Committee of Michu People's Hospital, and a written informed consent was obtained from all the participants. It included women more than 18 years of age who had experienced at least 2 or more early abortions, who had a normal reproductive tract anatomy and normal karyotype, and they were negative for autoimmune disorders. And also women had they were negative for blocking antibodies before the LIT treatment. They excluded women with infectious disorders, autoimmune diseases, and malignant tumors. LIT was prepared using donor, mostly patient husbands. Blood was taken and they were screened for infectious diseases. 30 ml of fasting venous blood was taken in EDTA tube. Lymphocytes were isolated by density gradient centrifugation using fecal hypake solution. Lymphocytes were then dissolved in physiological saline at a density of 1 into 10 to the power 7 cells per ml. 1 ml of the lymphocyte solution was intradermally injected at 5 points on the forearm, 0.2 ml per point. LIT treatment was then performed once in every 3 weeks, and after the 4 doses, it was considered as a single course. Once the course was over, 2 weeks later, the patients were tested for the production of blocking antibodies. If blocking antibodies were present, that is, they were positive, the LIT was then given once in every 4 to 6 weeks, and couple were asked to try for pregnancy. If the blocking antibodies were negative, then the LIT course was repeated. After pregnancy, the LIT was given once in every 2 to 3 weeks until 16 weeks of gestation. Blocking antibodies were tested using ELISA kit. It contained IgG antibodies against HLA class 1 and class 2. It was said to be positive when the optic density value was above 0.2 times the normal serum control. Statistic analysis was performed using SPSS 20.0 software, and the p-value of less than 0.5 was considered to be significant. Coming to the results, when the baseline characteristics were seen between the LIT and the control group, there was no difference found in the baseline characteristics, and it was similar. When when patients in the LIT group who became positive for the blocking antibodies, when they were compared with the women who were negative in the baseline characters, they found no difference in them. The baseline characteristics included the maternal age, pre-pregnancy BMI, infertility duration, miscarriage rate, and primary recurrent spontaneous abortion. All these rates and parameters were similar in both the groups. When blocking antibody conversion rate was observed, the more the number of LIT treatments, the more was the conversion rate. Women with less than 4 times, 52% became positive when they received less than 4 times. When 4 to 6 times, 75.7% were positive, and women who received more than 6 times, 90.6% had become positive. A total positive blocking antibodies was seen in 77.9%. When compared to control, it was only 11.9%, and it was statistically significant. Comparing the clinical outcome, the pregnancy outcome, it was seen that the pregnancy and the live birth rate in the LIT group was significantly high when compared to the control group, and the abortion rate was significantly low in the LIT group and compared to the control group. When analyzing the independent factors that were associated with the benefit of LIT, it was seen that maternal age of less than 35 years and the presence of blocking antibodies were the 2 parameters that had a better two parameters that showed better clinical outcome in the LIT group. So studies have shown that immunological dysregulation play an important role in the occurrence of unexplained recurrent spontaneous abortion. Fetuses are recognized as semi-allograft by the maternal immune system. Blocking antibodies, which are spontaneously produced in mother, function as a normal mechanism, and they prevent the rejection of fetus. On the contrary, failure of production of these blocking antibodies will lead to pregnancy loss. Systemic review and meta-analysis by Muehlman et al. In 2015 demonstrated that specific HLA alleles and HLA sharing are associated with failure in production of these blocking antibodies. LIT immunization stimulates the maternal immune system and motivates the production of these blocking antibodies. In this present study, it was observed that 77.9% with unexplained recurrent spontaneous abortion patients became positive for blocking antibodies after LIT, and the conversion rate increased along with more LITs. Accordingly, the pregnancy rate increased from 29.6% to 65.3% after LIT, and the live birth rate also significantly increased from 50.6 to 80.3%. Thus, results suggest that LIT significantly improved the maternal immune balance and pregnancy outcomes. These findings were consistent with another study by Chen et al., who suggested that LIT significantly improved the pregnancy outcome in unexplained recurrent spontaneous abortion patients. Another study by Porakabi et al. Indicated that LIT effectively treated unexplained recurrent spontaneous abortion patients when an appropriate dose of fresh lymphocytes were injected intradermally before and during pregnancy. However, meta-analysis by Achille et al. Implied that LIT may not increase the live birth rate. However, the conflicting findings may be partly attributed to the variations in the research protocols such as selection criteria, diagnostic testing, and treatment methods. Limitations of this study was that it was a retrospective study, hence the selection bias could not be avoided. Other immunological markers of recurrent spontaneous abortions like T helper 17 to T regulatory cell ratio, the TH1 to TH2 cytokine ratio could not be assessed. And in recurrent spontaneous abortion patient who did not get pregnant within 3 to 6 months opted for IVF, and the effect of LIT on IVF was not studied. To conclude, the present study suggests that the LIT effectively induced the production of blocking antibodies and improved the pregnancy and live birth rate. Blocking antibody conversion and younger maternal age were independent factors that were associated with the effects of LIT. These findings supported that LIT has a beneficial treatment for patients with unexplained recurrent spontaneous abortion. Here I am presenting data from our center, that is Gunashila Fertility Center. We evaluated the role of LIT in improving the pregnancy outcome in RIF and RPL. It was a retrospective observational study conducted between August 2019 to April 2024. Couple was screened for HLA typing to look for the sharing in the HLA gene. It's 6 loci: A, B, C, DRB1, DQB1, and DPB1. Partners with HLA antigen sharing were assigned a score ranging from 1 to 12. 433 couples were screened during this period, and 343 couple had an HLA sharing of a score more than 1. They were further divided into 3 groups. Group A were only recurrent who had recurrent pregnancy loss. Group B, women who had only recurrent implantation failure, and Group C, who had both recurrent abortion as well as recurrent implantation failure. In couple with a score of more than 1 by 12, parental lymphocyte immunotherapy was given before conception. 2 to 3 doses were given at an interval of 6 weeks. During pregnancy, if the score was less than or equal to 3, women received 3 doses of LIT, and if score was more than 3, then women received LIT every 4 weeks till 28 weeks of gestation. Pregnancy positive patients were followed up and analyzed. So in group A, recurrent pregnancy loss were further divided into primary and secondary. In primary RPL, the clinical pregnancy rate and the live birth rate were significantly high in the LIT group when compared to no LIT. In secondary RPL, the live birth rate was significantly high in the LIT group. In group B, that is RF patients, the clinical pregnancy and live birth rate both showed a significant increase in LIT group when compared to no LIT group. And in groups, that is combined RPL and RIF, the clinical pregnancy rate was significantly high in the LIT when compared to no LIT. So the live birth rate was high in the LIT. There were no live birth rate in the LIT group to be compared with. Coming to the timing of the LIT, it was observed that when the LIT was given before and during pregnancy, the live birth rate was significantly high in all the 3 groups when compared to just given before pregnancy or during pregnancy. So controversies that are around LIT. The Cochrane review in 2014 elaborated that various immunological treatment options for RPL and concluded that there was no significant improvement of live birth rates following LIT. This was criticized because the study by Ober et al. Was the first and the only study to show a negative effect of LIT on the pregnancy rate. Firstly, they used paternal lymphocyte that was stored overnight, and they did not exclude patients with autoimmune conditions. So Clark et al., the CD200, which was expressed on the dendritic cells, play a crucial role in the development of immune tolerance and are required in sufficient number to achieve an immunomodulatory effect. Now, storage of these lymphocytes in low temperature and for several hours reduce the CD200 cell counts, and which could compromise the immunomodulatory effect. Thus, a repeat analysis of the Cochrane in 2014, excluding the Ober et al., showed that a significant increase in the live birth rate following LIT with partner's blood. The recent meta-analysis showed the odds ratio of live birth rate significantly more, ranging from 3.2 to 4.02. However, the international bodies like ESHRE, RCOG, and ASMR do not recommend the use of ASRM, do not recommend the use of LIT in recurrent pregnancy loss. A meta-analysis by Liu et al. Observed that LIT did not improve the success rate of European and American patients. However, the Asian patients, the success rate was significantly higher. Unfortunately, in the absence of any clinical data from the Asian and African countries, there are no guidelines released by any of the Afro-Asian bodies. It is time these countries generate new evidence with well-constructed multicentric RCTs. Thank you.
Thank you.
No,
Very, sir, please.
we can ask any questions, Dr. Vani.
And I was going to say it's a very, very nice presentation, and we want expert comments from Dr. Devika, and then people can ask questions, sir.
Good, good.
You're muted, Dr. Devika.
Okay. There are several immunomodulatory mechanisms that take place in the maternal-fetal interface, and involving not only the HLA class of antigens, which basically is a class of antigens that we require for our basic living. It is HLA group is basically used for processing and presenting foreign antigens to the T lymphocytes. So there are two types of HLA. There's class 1 and class 2. And HLA class 1 again can be divided into classical and non-classical. And all of them, the HLA class 1 is involved in stimulating the T lymphocytes. So you get a cytotoxic response. Whereas the class 2 is important to stimulate the B lymphocytes, and that produces an antibody response. So that's how they work. Now, the number of immunomodulatory mechanisms that are taking place in the maternal-fetal interface is huge. So it would be very simplistic to assume that, oh, if the Th1, Th2 ratio is abnormal, then we have to, give them something like an immunomodulator like tacrolimus or HCQ, or that is going to help the pregnancy, or only, producing blocking antibodies that would help the pregnancy. Now, why do we need blocking antibodies? Because the fetus is a combination of the mother's and the father's antigens, and the paternal antigens are foreign to the mother. So in very simple terms, when the fetus goes and gets implanted into the uterus, immediately there's an intense antibody reaction, immunomodulatory mechanism, which actually aims at destroying the uterus. But because the fetus is, shall we say, anatomically separate from the mother, and it is still immature in its antigenicity, the mother also has a lot of immune tolerance. So what happens is that it produces a layer of blocking antibodies around the fetus, preventing her innate immunological mechanism from recognizing the fetus as foreign. So that is the basis. So for that to happen, there are Th1, Th2 cells where the ratio should be in favor of anti-inflammatory response. There are T regulatory cells, there are T17 cells which should be decreased. So many mechanisms that take place. And every time I read it, I remember it for that particular talk, and then I forget it. So the number of immune mechanisms is huge, and then they continue talking about IL-2, IL-3, IL-4. What are the others, Ashwini? IL-17, etc. So many mechanisms that are in place. So we can't just say that one particular modality of treatment is going to work. So we are looking at we do a lot more immunotherapy, isn't it, for people who are more than 3/12. So we match the 6 loci. Can you tell them the loci that we match?
Ma'am?
The loci that we match are ABC,
DRB1, DQB1, and
one more
Q.
D.
T,
One,
DR,
there is
DQ and R, ma'am.
DQ
and DQ,
Yeah.
DQ.
PQ and R. Yeah,
DQ and
PQ and R.
DQ and R.
Yeah, so the thing is that so there are 12 loci that are matched, and so 1 and 2 is not very significant, but in more than 3 we consider it significant, and we keep giving repeated lymphocyte.
Until up to 28 weeks, we will see based on how the pregnancy is progressing. If they have any IUGR, if they are having like on uterine artery that notch or Doppler is not good, if they're positive, then we continue it up to 28 weeks.
Yeah, so that way our pregnancy rate has increased, and now we're trying to use it for RIF,
Live
and
birth rate
that is something that is ongoing.
ongoing. Yeah.
But there are other things also like tacrolimus and HCQ which one can use if the HLA is low. But HLA has really helped. I mean, according to me. I mean, according to X-ray and ASRM, you can't give them anything. Even so, amongst all the various treatments is aspirin, Clexane, IVIG, intralipid, which people are giving right, left, and center. And each one of them, they always say that the risk of giving it outweighs the benefits. And then the last is TLC. So there is no
The TLC.
but with
Only
TLC also, there's
TLC.
no randomized control trial. So there's nothing for no evidence for anything. So I think we should actually make our own evidence, and I think we should actually start using it. And if anybody wants to send their people to see how to process the blood for lymphocyte concentrate, I'm very willing to show them. We already had a few people coming from Erode and Salem and things like that. So I think it's open to anybody who wants to come to us, our institute, and see how to process it.
In Bangalore, right now, we are the only center who are doing that
I think Apollo,
LIT processing.
no,
Yeah.
Apollo also does it, but then they're very much more expensive than us.
Expensive. So we get lot of referrals for LIT processing to our hospital.
Yeah.
So, when do you start this HLA matching? Like after routinely after 2 losses or after 2 RIF?
Yes, ma'am. We have a profile of investigations, which we have our panel of investigations in patients who have more than 2 or more recurrent pregnancy loss, early pregnancy losses, or less than 24 weeks. We do HLA typing as a part of a panel, and then we will wait for the
We want to rule out auto antibodies, like for example, APLA,
everything in the
PLA.
panel we rule out. We have a entire panel where we do APLA, SLE, homocysteine levels. Then we rule out endometritis. We rule out tuberculosis, and then HbA1c, vitamin D levels, karyotyping we do. In that panel only we also do HLA, and we ask them to not to conceive until the reports are out. And based on the scoring, we have our own scoring system. Like Madam was telling, that is up to 12 loci we will screen, and based on the scoring system, we will give them preconceptional PTLs. That is, 6 weeks intervals, LIT we give at 2 to 3 doses at 6 weeks intervals we give. Then we advise them to get pregnant. Once they are pregnant, we will, based on their scoring system and how the pregnancy goes about, we will continue the LIT. And we also, because none of them in Bangalore right now are doing any blocking antibody level measurement. So what we are doing is a T cell B cell cross match. Once that T cell B cell cross match comes positive, that means she's had a sufficient amount of blocking antibodies and further dose is not recommended. But recent studies have shown that only like ours also, our data we have shown that if we give only during before pregnancy, it's not sufficient. It has to be continued during pregnancy also until 20, like few studies have shown 16 weeks, few have shown 20, 24 weeks. So we continue.
For women who are Rh negative,
Yes.
and
In
the
women who are,
husband is Rh positive, what
yeah,
happens is that we will still, before we used to look for third
third
party
party.
transfusions, I mean, or injections. But then it has been very difficult because we didn't want to, recommend any third party. We do not know who that person is and what their habits are and their HIV, HPSAG status, etc. So we would ask them to get their own people to come and give it. But that became very difficult for the patients also to keep asking them to come every 6 weeks and give the blood. And we take about 80 to 90 ml of blood, and final concentrate is like how you get a small pellet in the sperm when you actually kind of centrifuge it in the end. Similarly, you get a small pellet of lymphocytes, and that is taken and diluted with about 1.5 ml maximum 2 ml of saline, and give it intramuscularly 1 ml in each buttock. We don't give it intradermal, although intradermal is supposed to be more immunogenic. Yeah, it has to be poked so many times, so I don't like to do that. So I just want to give 1 ml in the each buttock. So now what we do is, if there is an Rh negative lady, we actually estimate the quantity of RBCs in the quantity that we're going to inject. And
processed sample, in the process sample, we'll take the RBC.
In the final sample, and then it should be less than some 0.4 something RBCs into 0.4 into 3 something per microliter or something. Ours comes up to 0.1 to 0.2 usually. And also our we estimated the amount of lymphocytes in the amount that we actually inject, and that's about 78 to 80% of lymphocytes. So that's how much we're injecting. And what we do for an Rh negatives, now we take the husband's blood, even if he's Rh positive, because the volume of RBCs is so low. For every sample we check it, and then we give an anti-D before giving to the patient, before we give the injection. That's a day before, isn't that correct? Yeah.
Yes, ma'am. 1 day before we give anti-D, and the next day we will process and give them the LIT.
Yeah.
And we have tested those patients in the later part for like Coombs test for any positive antibodies. It's been negative only. None of them have had any seroconversion.
And when we were actually doing the third party LIT, because it was becoming a pain for the patient to get this person every time, we started to do the T cell, B cell lymphocytes. So what happens is, usually you look at the B cell antibody production, and usually that comes out first, but we're not looking for that. We're looking at the T cell lymphocyte production. So once the T cell lymphocyte production happens, for this specific group of Rh negative people, we don't want to burden them with giving so many injections. So we kind of we play it by ear. We give them 1 or 2 doses, and then we will see how the pregnancy continues. And then if she starts to have again bleeding, or trying to miscarry, threatening to miscarry or whatever, then we might give them 1 more dose.
That's
yeah, Dr. Vani, can I ask 2 questions?
yes,
No?
sir, yes,
Yeah.
sir, please, sir.
Dr. Devika, what are the common adverse reactions you come across during this treatment? No, that's one question.
Yeah.
And second, a basic question. Usually, these blocking antibodies are they are dependent on the progesterone. No, they are progesterone-induced blocking antibodies. So, do you find any progesterone deficiency in this particular group of patients? Actually.
Okay, to answer the second question first, we have most of these people are women who come for, who get pregnant spontaneously. So we are not really estimating the progesterone either at the time of pregnancy test or whatever. We don't do it, but then we do because it is a multi-pronged approach. We do give them progesterone for support. So that is one thing that we do, but we have not actually looked at this particular situation where their progesterone levels are low. That is a good idea. I think we must try to do it in our patients who are coming for IVF who also have RPL. The second point is that we've hardly had any reactions. They only feel slightly feverish, or they have a little bit of swelling in that area, and because it's a deep IM, really nothing much they complain about. And we've done plenty of patients, so we've been doing it for a long time, so there's hardly anything. But what is there in the literature, there has been one reported case of congenital
Neonatal
thrombocytopenia. There's been one reported case. So that is the only thing that that has been reported as of now in the world.
Okay. Thank you. Thank you so much. Thank you.
Thank you, sir. Thank you.
Do you combine with any other immunomodulators like heparin or HCQ or steroid?
Yeah. We have not used that much of HCQ or tacrolimus, but I'm planning to do it. And I'm also, if you read the literature, with tacrolimus, basically they are trying to alter the TH1 TH2 ratio. So the TH1 TH2 ratio should be more in favor of increasing TH2 than TH1, because TH2 is T helper cell 2 is a immunosuppressant. I mean, it is anti-inflammatory basically. So tacrolimus acts by decreasing some of these TH1 cells. So I'm trying to see whether we can actually, any place any place either in Chennai or in Hyderabad or in Bangalore that is one that can do TH1 TH2 ratios, I would like to do a study on that and see if for these women who actually have less than 3/12 HLA, whether we can actually add on tacrolimus for them. That is one thing. Second thing is that we have had very limited experience with HCQ. We have given it to a patient who's had something like one live birth, secondary RPL, one live birth followed by 6 or something abortions, and her pregnancy now is about 32 weeks, and we have given her HCQ in this pregnancy, and it seems to be going on because her HLA matching was 0/12, so there was no matching at all, and she kept bleeding throughout her early pregnancy, and there was so much of bleeding. I mean, every time she'll come and get admitted. Then there was no way we could not give her any Clexane or aspirin or anything because every few days she would come back with a bleed. So then we started off this HCQ, and she seems to have done pretty well with it. Yes, we do give Clexane also because I do feel that this is a multi-pronged approach. It is not only one, a particular immunomodulatory cell that you're targeting. It's a large number of cells. So some people, I was talking to some people in Hyderabad, they give live in intralipid because they are testing the NK cells, but we've not had too much of success with it because we did do a study which we didn't publish because I do not know, we didn't think it was good enough, where we actually looked at the uterine NK cells. So the patients underwent 2 PIPL biopsies looking at the uterine NK cells, and if that CD56 bright came out as more, then we actually gave them intralipid and then again did another PIPL. The patients were very cooperative. We had about 350 patients like that, but then our pregnancy rates didn't show. It was in the range of some 35% or something after that kind of treatment. So we really didn't. We stopped that, and I'm worried about intralipid because it can produce fat embolism.
Okay.
Yeah, but we do give progesterone, and to a large number of patients, we do give a low molecular weight heparin along with it.
Anybody else wants to say anything or ask questions? Dr. Radha? I think I saw her there.
I think you can conclude, Dr. Vani.
Thank you very much for a very nice presentation, and we.
I just want to add one thing.
Yes, Dr. Radha.
Yeah, actually, we were giving small lipid for some of the patients with the previous one APT, one transfer failure. We have not used intralipid, but just wanted to know because Madam was saying about the fat embolism. In our experience, we had more number of patients with allergic reactions.
I see.
So, so I was just thinking whether we should concentrate on that because we have published a paper recently, which is going to get published in the Fetal Medicine Journal now. It is accepted for publication. So we have compared it, and we found that after giving intralipid for these patients after one FET failure, the pregnancy rate was almost comparable to those without having any failure. So
Okay.
that is what we observed in that study. So I'm now thinking twice whether the risk of fat embolism is very high. Should we think about it? We keep them as a daycare and observe them after they are administering the drug. Small lipid we are giving, and after that, if they don't have any reaction, we are sending, and we give it after, once the pregnancy test is confirmed, and one more at the end of 10 weeks.
Yeah,
so we are giving 3 doses to them.
That's excellent data. I'll be looking forward to seeing that that publication. That'll be really good to read. I said that we were giving intralipid, but we give it very, very slowly, and we don't dilute it with anything because it really doesn't mix with saline.
Yeah.
So we give it very, very slow over some 6 hours or something like that. It's a 100 ml bottle or something, no?
Yes, ma'am.
It's
Yeah.
only or slowly, and we are administering, keeping other drugs ready for in case he has any allergic reaction.
Yeah.
That is our experience which I think we should share.
We didn't have, thankfully, we also didn't have any fat embolism, but that's what is said in ESHRE guidelines. But if you go by ESHRE guidelines, you don't have to do anything. You can just sit quietly and watch them expel. That's all.
Yeah. Dr. Devika, what about immunoglobulins, intravenous immunoglobulins? No, usually all of our recurrent pregnancy loss patients, I do send them to hematologists. No, so we could save with 4-5 abortions. No, we could save the pregnancies, and they went back with live babies. No, so what is your experience with intravenous immunoglobulin therapy?
You can give them, because that's again with Eshe, that is the only medication or intervention that has some amount of evidence according to Eshe guidelines. But the problem is that you have to give 1 gram per kg body weight, which means that if the lady is 60 or 65 kgs, you have to give 65 grams each dose.
Yes.
And it becomes very, very expensive.
You are right. Yeah.
I think for 5 grams, it is somewhere around 12 to 15,000.
Yeah,
So
no
what,
more than that, Dr. Ashwini, because almost 30,000 rupees or something it is working out. No, so they'll get admitted, and very slowly, no, over a period of 24 hours,
And
they'll be healed.
yes, sir, slowly we have to give.
It
very
does work
slow.
well. It does
Yeah.
work well. And like I said, there are so many therapies, each one working at a different level. So if actually, we have to kind of find out which is the immune mechanism that is actually at fault, it I think is going to be impossible, because as it is, that immunology is one terrible subject, very difficult to understand and also very difficult to remember. It is highly volatile.
That is the final conclusion.
So I think it should be a multi-pronged approach. And I think, there's somebody who has said what is the role of bar globe? I really do not know, because I have not used it. It's maybe it can be tried, but I'm not too sure as to how much the dose is when you're giving it IM like that, or subcutaneous. I do not know how they give it also. So I don't have any experience in bar globe. I'd appreciate it if somebody else shed some light on it. But then it has to be a multi-pronged approach. It cannot be only one thing, because we really do not know. Still, we are in the dark, and we do not know what
we are dealing with.
What we're targeting.
Thank you.
Thank you, sir. Thank you very much.
Thank you, ma'am. Thank you so much, Dr. Devika.
Yeah, thank you very much for including us. We are highly honored and very grateful for the opportunity.
Thank you.
Thank you, Dr. Gunshila. Thank you very much.
Thank you, ma'am. Thank you, sir.
Thank you, Dr.
Thank you. Thank you, ma'am.
Can we proceed, ma'am? Thank you all. For the next session, I'd like to introduce the chairperson for the next session, Ms. Amita. Sahiti, can you please share Ms. Amita? Ms. Amita Subramanian, she's a consultant senior embryologist at Cloud9 Fertility Tinagar. She's previously worked at Srishti and Shantati Center, Bangalore. She is a member of ESHRE, ASIFS, and TOGI. Ma'am has several academic presentations, and her special interests include advanced sperm selection, oocyte dysmorphology, and ART outcomes.
43, 9:15 கொடுத்துரு சாப்பிடுறியோ இல்லையோ
Amita ma'am, I kindly request you to introduce the speaker, the topic, and the expert for today, please. Amita ma'am, can you unmute yourself, please? And
can you hear me?
Yes, ma'am.
Hi. Thank you for the kind introduction, Dr. Sindhu, and the opportunity to chair tonight's session on the TAPISAR's Journal Club. So for tonight's session, we have Dr. Priya Kannan as our expert for the topic. She needs no introduction. Ma'am is a senior embryologist and director of Garbharaksha Fertility Center, Chennai. And she's held several positions in IMA and in ACE and several organizations. She's authored many chapters in various textbooks and has participated as invited resource in many national and international conferences. Ma'am has been past president of ACE and organizing chairperson of ACE Chennai and an EC member of ISAR 2020 to 2022. For today's presenter is going to be Dr. Narmada R. She is a senior clinical embryologist at the Lalitambige Fertility Center. She's done her PhD in sperm proteomics, and she's got a master's in clinical embryology from Ramachandra, and she's done her MBBS also from there. Work experience, she's got more than 6 years of experience in clinical embryology, and she's served as a senior embryologist in Aishwarya Fertility also. She's a gold medalist in 2018 for the best outgoing student in clinical embryology, and she's also a member of ASNSR. So for the topic for today, the journal that they have taken up for today's discussion is a systemic review and meta-analysis of indirect markers of oocyte quality in patients with ovarian endometriosis undergoing IVF for ICSI. So this is a September 2024 publication of Reproductive Biomedicine Online Journal. I would like Dr. Narmada to now take over and discuss the paper in detail. Thank you.
Good evening, everybody. Thank you, ma'am, for your kind introduction, and I thank TAPISAR for this opportunity. And today I'm going to present the journal topic, which is a sorry. The slide is not moving. Just a minute.
Sindhu, her slides are not moving, it seems.
Ma'am, please click on the screen, ma'am, after sharing the slides.
Okay, fine. Now it's.
No, we cannot see the slides, ma'am.
It is not shared.
Can you see it now?
No, ma'am.
Can you share it
Click
again?
on the share, Narmada. Then
I just
click on
shared,
the
ma'am.
screen again.
Yeah, I'll do. Thank you.
Yeah.
Can you see, ma'am?
Yeah, we can. Do you want to go to the yeah, that's right.
Double click on
Go
the
ahead.
slide, ma'am.
Yes, yes, it's moving.
Oh, thank you, ma'am. Thank you. Today I'm going to present a review article which is published in Reproductive Biomedicine Online. The title is Indirect Markers of Oocyte Quality in Patients with Ovarian Endometriosis Undergoing IVF ICSI, a systematic review and meta-analysis. Place of study is Department of Gynecology, Obstetrics and Reproductive Sciences, Yale University, USA. Duration of the study, they included articles between Jan 1990 and October 2023. Introduction. Endometriosis is a benign chronic hormone-dependent inflammatory disease characterized by the presence of endometrial tissue outside the uterine cavity, which affects 5 to 10% of fertile women and 25 to 50% of infertile women. And it is associated with infertility in 30 to 50% of cases. Etiopathogenesis and plausible factors suggested in the literature include altered folliculogenesis leading to the poor quality oocytes, exposure to a hostile inflammatory environment, dysfunction of the tubo-ovarian anatomy causing mechanical interference with oocyte uptake and transport, oxidative damage, immune reactions that may impair embryo implantation. The ovarian endometriomas are cysts containing ectopic endometrial tissue and represent a common form of endometriosis, affecting 17 to 44% of patients. The toxic inflammatory content of the cyst has been shown to cause fibrosis, structural distortion, and vascular deterioration in the surrounding ovarian cortex, leading to the loss of primordial follicles with oocyte attrition, early activation of follicular recruitment, follicular atresia, and diminished follicular density and ovarian reserve. The data also suggests that the free iron from OMA diffuses out of the cyst to the surrounding ovarian tissue, contributing to the oocyte attrition. Some studies have also indicated that this damage is clinically negligible and the presence of OMA per se does not cause infertility. Few authors also reported a lower number of oocytes retrieved after ovarian stimulation in patients with endometriosis compared with the controls. It is plausible that the current chronic inflammatory state of OMA could have a severe impact on oocyte quality. Several molecular targets are being investigated in efforts to establish direct markers of oocyte quality, but have not yet demonstrated the clinical value. Given the current lack of direct indicators, indirect markers such as fertilization, blastulation, and euploidy rates are used to estimate oocyte quality in clinical settings. The molecular, histological, and morphological evidence showed that OMA has a detrimental impact on IVF results, both directly by reducing the ovarian reserve and indirectly as a consequence of related surgeries. The available clinical data regarding fertility treatment outcomes in patients with OMA are highly heterogeneous. The recommendations concerning surgery prior to IVF are often based on expert judgment rather than the evidence. So the aim and objective of the study is to evaluate the impact of ovarian endometriomas on indirect markers of oocyte quality in patients undergoing IVF compared with women without anatomical or functional ovarian abnormalities. The primary objective is to compare oocyte quality in infertile women with OMA undergoing IVF ICSI compared with women without endometriosis and healthy ovaries. The secondary objective is to assess differences in oocyte yield between the groups. The inclusion criteria, they included all randomized control trials, case control studies, and cohort studies from January 1990 up to October 2023, which is reporting fertilization, blastulation, and euploidy rates in IVF ICSI cycles in patients with OMA at the time of IVF ICSI were included. Duplicate search results and unpublished articles were excluded. The study eligibility criteria include infertile patients with either unilateral or bilateral OMA at the time of ovarian stimulation. The intervention is with IVF ICSI with or without PGTA. The controls are the infertile couples with or for other lesions without anatomical or functional ovarian anomalies. The primary outcomes were fertilization rate, blastulation rate, and euploidy rate. The secondary outcomes were the number of oocyte retrieved, the number of M2 oocytes retrieved, the number of top quality embryos, and the ovarian sensitivity index and the cancellation rate. Exclusion criteria, the history of OMA but no lesion at the time of IVF, suspected malignancy, other anatomical or functional ovarian alterations, or diminished ovarian reserve. Risk of bias and quality assessment. The quality of the case control studies were assessed using the Newcastle-Ottawa scales. On this scale, studies are rated in 3 categories. That is subject selection, with the score of 4/4, study group comparability with 2/2 score, and outcome or exposure assessment with 3/3 score. The studies were categorized as low quality with scores 1 to 3, moderate quality with scores 4 to 6, and high quality with scores 7 to 9. The quantitative analysis, a Mantel-Haenszel model and a fixed effects model were employed to determine the pooled effect of each variable. The odds ratio was calculated to assess the fertilization, blastulation, and cancellation rate. The total number of oocytes retrieved, number of M2 oocytes, ovarian sensitivity index, and number of top quality embryos were compared by the difference in means. The p-value less than 0.05 were considered to be significant. Search and selection criteria. The total of 900 studies were identified, out of which 890 studies were screened, and only 50 studies were assessed for eligibility. And finally, total of 31 studies were included in systematic review and quantitative synthesis. The analyzed studies included a total of 12,995 participants, with 2,809 women in the OMA group and 10,186 in the control group. Most observational studies had scores more than 7, and only 3 studies had a lower score. Results, the primary outcomes, first is the fertilization rate. This could be analyzed in 8 studies included in this review. And 4 of them found no significant differences between the study group. This meta-analysis found no significant differences in the fertilization rate between patients with and without OMA. Next is the blastulation rate, which is analyzed in 6 studies, and 5 of them found no significant differences between the study groups. The present result showed an odds ratio of 0.86. Next is the secondary outcome. The total number of oocytes retrieved was analyzed in 30 studies included in this review, most of which reported a lower average number of oocytes retrieved in patients with OMA, with over half of the differences being significant. Only 2 studies showed an increased oocyte yield in patients with OMA. The present meta-analysis found a significantly lower total number of oocytes retrieved in patients with ovarian endometriomas. The number of total M2s, just a second, The number of total M2 oocytes retrieved was evaluated in 17 studies included in this review. 13 studies found a significantly lower number of M2 oocytes retrieved in patients with OMA. 3 found no difference between the groups, and 1 reported a higher number of M2 oocytes retrieved in patients with OMA. The present meta-analysis found a lower number of M2 oocytes retrieved in patients with OMA. Next is the number of top quality embryos, which is assessed in 7 studies, which indicated that number of high quality embryos obtained in the patients with OMA was significantly lower compared with the controls. Next is the ovarian sensitivity index, which is analyzed in 4 studies. 3 of them reported a lower number of oocytes retrieved relative to the magnitude of ovarian stimulation in patients with OMA compared with controls. 1 reported a comparable sensitivity index. The present analysis did not find a significant difference in sensitivity index. Negative FE number of M per IV cycle compared with controls, which is a fertilization rate, found no difference in the fertilization rate between patients with OMA. A systematic studies showed a lower fertilization rate in patients with endometriosis stage 1 and 2 controls, but found no difference in the fertilization rate between patients with endometriosis stage 3 and 4. A more recent meta-analysis found a reduced fertilization rate in patients with endometriosis compared with the controls. The blast rate, it is another indirect marker of oocyte quality. 6 are evaluated the blood relation rate alone and found no significant difference between patients with OMA and controls. Next, the ovarian sensitivity. The present meta-analysis found no differences in sensitivity index between patients with OMA and controls, which is based on the individual studies. Next is the gonadotropin dose. Some meta-analysis found no difference in total dose of gonadotropin used during ovarian stimulation between patients with OMA and controls. The present results indicate a distinct pattern which is characterized by a non-significant trend towards requiring higher gonadotropin dosages for ovarian stimulation and a lower overall oocyte yield. The lower sensitivity index in patients with OMA could be attributed to various factors associated with endometriosis, which is ovarian reserve depletion, impaired follicular development and inflammatory microenvironment, fibrosis and hormonal change, necessitating increased doses of gonadotropin to achieve similar number of oocytes. Next is the top quality embryos. Meta-analysis identified a lower number of top quality embryos in patients with OMA compared with controls from 8 studies included in this review. Next is the euploidy rates. Retrospective cohort study found that the euploidy rates in patients with endometriomas was significantly lower compared with the controls, whereas 2 extensive studies focused on patients with endometriosis found no differences regarding aneuploidy and euploidy rates. Conventional IVF or ICSI, a lower fertilization rate in patients with endometriosis undergoing conventional IVF cycles compared with those undergoing ICSI cycles. The superior outcomes associated with ICSI supports the theory of zonal thickening in patients with OMA, and it is postulated that injecting sperm directly into the oocyte can enhance the fertilization rate. And there is a controversy over whether oocyte quality and performance are affected by the presence of OMA itself, or it is due to ovarian surgeries that many patients undergo prior to IVF, which would affect their ovarian reserve and potentially their response to the ovarian stimulation. They compared few results and showed OMA per se is not associated with increased risk of infertility, while history of surgery for endometriosis is associated with increased risk. The next result showed history of surgery for OMA is an independent risk factor for poor ovarian response. And when comparing meta-analysis, patients with OMA and ovarian cystectomy compared with patients who had not underwent found no significant difference in oocyte competence. And operated patients with intact OMA, suggesting that OMA per se could be associated with detrimental impact on oocyte quality. And when they compared results with the retrospective cohort study, they found surgical treatment can have an adverse effect on oocyte maturation and also a positive influence on blastocyst development. Next, cumulative live birth rate was not inferior in patients with OMA compared with controls, although a reduced blastocyst formation rate was found in patients with OMA. OMA and ovarian surgery can notably reduce the ovarian reserve, and considering that OMA does not appear to have a negative impact on oocyte quality or embryo development, recommendations for cyst removal are controversial and counseling should be individualized. Limitations. The main limitation is assessment of oocyte quality through indirect markers. As the definition of oocyte quality using direct markers with clinical significance has not been established to date. And the effect of previous ovarian surgery in the study population, next to the influence of extra ovarian endometriosis among the patients, which they do not have the precise image testing performed to stage the endometriosis, and inclusion of women with either unilateral or bilateral OMA. And most studies did not specify the number of IVF or ICSI cycles conducted in each group. And difference in patient characteristics between the studies with variability in the extent of endometriosis between the studied population. Limited evaluation of the euploidy rate in patients with OMA. The clinical impact and conclusion. The findings strongly suggest that OMA may not improve oocyte quality in despite a reduction in the overall yield of oocytes. The observed trend of a potentially lower oocyte sensitivity index in importance for comparable potential to women without OMA. As lower total and M2 oocytes may be obtained, a recent recommendation suggests that at least 10 to 15 oocytes should be cryopreserved if the patient is willing to undergo cultivation to increase the chance of achieving a future pregnancy. Further research is warranted to increase understanding of the cytotoxic impact of ovarian endometrioma on the surrounding follicles and quality. A broader evaluation of embryonic euploidy in patients with ovarian endometrioma is essential. Thank you.
Thank you, Dr. Narmada, for explaining the journal in detail. It was very concise and crisp. Dr. Priya ma'am, your expert opinion on endometriosis and the ovarian endometriomas, oocyte outcomes, oocyte quality. Please enlighten us about that.
Thank you. Thank you very much for the invite, first of all, and for involving me here. It's a great paper. I had also gone through this, and I was like little puzzled myself because it has, we have always had a different opinion, and that's what, and suddenly this comes around and says, look around, you just have a decrease in the oocyte numbers in the M2, but nothing else is affected. But of course, they have not looked at the pregnancy rate in this. So, which ideally is the only point that we are looking at, even though we have less M2s or anything, that is what we'll be looking at. Of course, here it says that the blastulation rate is also the same, and but of course, we'll have to look at the pregnancy rate. As Narmada has beautifully presented in previous papers, we have had publications where it's shown that the more severe the endometriosis, they seem to have lesser effect than the milder ones. But of course, it's always been controversial on that aspect. This was quite a surprising paper for me as well. I had gone through it and I was just looking at it. But of course, I think anything that we are looking at, though the blastulation rate is similar, the fertilization rate is similar, except that we've had lesser amount of eggs in the M2s, we would have to look at as an extension of this, the pregnancy rates. That what would ultimately, that's what we are looking at. But I don't know if I missed that when I went through the paper. Narmada, I don't know. Did it have any age limit as the criteria or of the inclusion or the exclusion criteria?
They didn't have any age limit, ma'am. Just that they just seen a lesion in the ultrasound and they have included in the study. So
Okay.
that maybe will be the subgroup analysis they didn't do actually.
Yeah,
so
I mean, I thought I missed it, but I was just wondering if there is an increase more of an older woman. Obviously, the egg numbers would be lesser than as compared to the younger women. So that is something I thought would be a limitation of this particular study. Apart from not reporting on the pregnancy rates, the next thing would be the age, because even if it's a milder disease, an older woman with a milder disease would have a lesser number of eggs as compared to somebody as this, and they didn't have the ovarian reserve, any of the ovarian reserve marker as the cutoff for inclusion or the exclusion criteria as well. So if we have lower number of and as you rightly pointed out, they didn't tell us the subgroup analysis, how many IVF or the ICSI they had, because if they had gone with ICSI most, then their fertilization wouldn't probably be affected as well. So I think, yes, this is not all in all a perfect thing to look forward to, but yes, we would have to take because some of the criteria that we know, or the confounding factors such as the age, the method of fertilization, and what we are looking for always, the pregnancy rates has not been reported. Those also would be, as you've rightly pointed out, the limitations of this analysis. That's something that I would look forward to. But of course, apart from that, what is your other publications apart from this publications? What have you gone ahead and looked at the pregnancy rates in terms of endometriosis in younger and in older, and as compared to mild and severe endometriosis?
Just that the live birth rate is increased without the endometriosis part, like the women without endometriosis. So the final part is the live birth rate we need. So that is the significant part. We can look into it.
Yeah, definitely. Thank you so much. You have done well, and you also were able to list out the limitations of this particular publication, and that's very good. Yeah, over to you, Amita.
Ma'am, just one question from you. Always the literature tells something and we see something different in our clinical work every day. So what do you generally see as an oocyte abnormality in patients with endometriosis? What oocyte abnormality do you generally see, ma'am, from your experience?
See, even if we don't know any history about the patient, the moment sometimes you look at the egg, and then with it has got a little bit more of granularity. And then when you're doing the ICSI, that particular field that you have, that you don't have that resistance in the olemma, you would turn around and ask, is the patient endometriotic? And usually it would 80 to 90% of them, it would be so. So that is something I've noticed, that the granularity of the cytoplasm would be slightly higher, and the resistance at the ICSI would be lower. So these are the things that I have seen. And of course, if when you look at the cumulus itself, it will have that the stiffness of the cumulus, and it will not be that pliable as your regular cumulus. That also with that, the clots in it as well. So
Yes.
these are the things that you usually look at, and then you're not able to pipette it as nicely smooth usually, and you would just by instinct you'll ask what is the indication, and you most probably would get the answer as endometriosis. Yeah, that's something I usually observe. What is your experience, Amita?
We generally see a little bit brownish eggs, darker eggs, inclusions in the perivitline space. That might be the reason why we end up with poor blastulation rates, because we generally see slightly lower blastulation rates in those kind of eggs. And even irrespective of the age, the equality is always on the lower side in patients with endometriosis.
But how do
even
you
with
say
younger,
that the egg quality is low? What are the indicators or the markers that you seem to have put more weightage on to make that
these
statement?
inclusions in perivitline space and even dark eggs, I'm not worried because we've had a good blastulation rates with that. But these inclusions in perivitline space, I somehow feel that kinds of prevents the embryo to expand into a blastocyst and kind of get stuck in the cell stage. Fertilization is still okay, but blastulation rates is always lower. Is
And
what I
do you observe more fragmentation in those embryos?
fragmentations also, yes.
Would be higher, so that
unequal cleavage and
yes,
fragmentation.
and that immediately brings down the grade of the embryo. So that's
Grade of the
something
embryo.
notice, but this paper was quite a pleasant surprise.
And we
Let's
also
call it that.
observed that post-60 degeneration rates are slightly higher when
It's also higher.
True, true. So that is it. I think we had one question here. Does all endometriosis has affected oocyte quality? Is there, can Narmada throw the point on it in terms of the mild, moderate to severe endometriosis, which you have already presented? Narmada, you're muted.
Only that stage 1 and 2, they had significant differences, ma'am. When compared with stage 3 and 4, they didn't get any positive results. Only with the stage 1 and 2. According to this study, they have
This
given
study,
results.
but have you seen any other study to see?
Same stages, stage-wise 1 and 2 is giving better results.
Yeah, but there's also been contradictory studies previously which said that oocytes were more affected in milder stages than in severe stages. There are 1 or 2 studies like that also. So we are not yet very sure, to answer that question, we are not very sure if there is a direct correlation between the staging of endometriosis to the oocyte quality. It is an enigma as such as of now. So we are not sure, but to be on the safer side, we assume that in any stage, the oocyte will be affected, because endometriosis does not just affect the oocyte, it also affects the entire milieu in the abdomen, and hence in the reproductive organ, in terms of, because of its pathogenesis, that we have a varied pathogenesis as well. So it not only affects the pregnancy rates are said to be lower, not only because of the oocyte quality, or also because of the implantation, the effect it has on the implantation as well. But we assume that all oocytes are supposed to be affected, and we said that's why we give some supportive medication for the patient, but there is no clear-cut idea on that.
Hi, Dr. Priya. Good evening.
Good evening, madam.
So you said in endometriosis, you definitely notice the quality of the eggs is low. Did you have a chance to see some of the patients who have been operated and then did the oocyte pickup, and did you find any difference in your personal experience? So, were the oocytes better once they are operated, something like that?
Ma'am, I'm not sure if I see the difference, madam.
Okay,
I don't think
there. Okay. So because there is always a debate and controversy whether if we operate, are we going to get better oocytes? So if it is not there, then should we operate at all? So that is one thing. I think this paper has said even whether we operate or not, it's not going to make any difference.
Yes, madam, because when you operate or not, it's not going to, I don't think I've seen a very marked difference in observation. But of course, when we operate, of course, we know that the number of oocytes do go down a bit, but maybe when we do a surgery on endometriosis and treat the endometriosis, maybe because of the varied pathology that endometriosis acts on, probably there is a slightly better pregnancy rate somehow we observe, is probably because of its impact on the implantation. It may not be it's not that endometriosis affects only the oocytes, it affects the entire milieu, which means the implantation. So when we reduce the inflammation and everything, probably implantation is more. So that could, it's just a fine balance of both that we are looking at, madam.
Yeah. So even if the AMH is okay, and even if we see good antral follicular count, once they have an endometriosis, we are likely to get very less oocytes, and I think that's what we gather from here. And whether we operate or not, the quality is not going to.
The quality of the oocytes remain to be compromised. I mean, that's what we see, but then this paper does not seem to show that. It's just because if just because the oocyte number is less, this paper seems to show that it does not affect the blastulation rate, but of course it's not extended it to the actual important one, which is the pregnancy rates. But if the blastulation rates are good, we assume that the pregnancy rate would be okay. But there's a lot of, I mean, that's something, an extension that we would like to see, madam.
Thank you very much.
Pleasure is mine.
Thank you very much, ma'am.
Anyone else wants to say anything? Sarath sir? Sir,
Sir
you're
is muted. Sir, you're muted, sir.
Muted. You're muted, sir. Sarath sir, you're muted.
Yeah. So, Priya,
Sir.
It's a wonderful presentation. I really appreciate your participation. And one thing, no, I never interfere with my embryologist, no, so I leave it to the embryologist. No, so my embryology knowledge is very poor. But anyway, I really appreciate. No, thank you so much.
Thank you, sir. Thank you for all the kind words you told, and thank you for inviting me, sir. It's always my pleasure.
It is our pleasure.
And you're being very modest when you say that your embryology knowledge is less and all that. We know, how knowledgeable you are, sir. You've been here for decades and you've taught all of us. We all have learned from you, sir. So
thank you, Doctor. Yeah, thank you so much. Yeah.
Thank you, sir.
Thank you, Dr. Vani.
Yes, sir. So we have learned a lot today. Thank you, Dr. and Dr. Devika.
And shall we call Radha ma'am for vote of thanks?
Yes. Dr. Radha?
First, I should thank Dr. Vani for accepting to do it in a very short notice. You and Sindhija coordinated very well, and you have got very good experts and chairpersons and the speakers. First, we should thank both of you for that. I thank Dr. Devika Gunashila and Dr. Priya Kandan for their expert opinion. And the next is the chairpersons also, they did a wonderful job. Dr. Ashwini and Dr. Amrita, both of them, and the speakers, Dr. Harshita and Dr. Mohmira. And I finally thank the Shield Healthcare for the platform as well. It was really educative and thought-provoking topics. Thank you very much for your active participation. All the delegates also, I would like to thank. Thank you, one and all.
Thank you.